Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen, faculty member from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School Duluth campus and a family physician at the Gateway Family Health Clinic in Moose Lake. I am your host for our program tonight on men's health and kidney stones. Remember, the success of our show is very dependent on you, the viewer, so please call in your questions tonight or email them to askask@wdse.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Josh Inglesjerd, a urologist at the Essentia Health System, Dr. Nick Johnson, a urologist with St. Luke's Urology Associates, and Dr. Paul Sanford, an internal medicine specialist with St. Luke's Internal Medicine Associates. Our medical students answering the phones tonight are Michael Gutman from Marshall, Minnesota, Alexis Code from Redwood Falls, Minnesota, and Kylie Schulke from Dawson, Minnesota. And now on to tonight's program on men's health and kidney stones. Gentlemen, I'd like to take just a moment to introduce yourselves. Dr. Sanford, can you tell us a little bit about your practice and what you do?
Oh, absolutely. I'm a general medicine, internal medicine physician, just do primary care for adults. Started in 1991 at what's now Essentia Duluth Clinic, and joined my parents, and they were already practicing up here. So, good bread and butter primary care.
And Dr. Johnson?
I am a general urologist here in Duluth at St. Luke's Urology Associates. I've been here for about 10 years, a little bit longer. I do a little bit of everything in urology, from stones to bigger surgeries to smaller procedures.
And Dr. Inglesjerd?
I'm Dr. Josh Inglesjerd. I practice at Essentia Health. I also do sort of general urology, a little bit of everything, but I do have a bit of a special interest in robotic surgery and cancer surgery.
Thank you. Welcome, gentlemen. Dr. Sanford, in your office, with your general medicine office, what are the common things you see from a urologic standpoint?
Oh, the most common is I have to get up every 2 hours at night to urinate. In men, we're just talking about men right now, aren't we? Yeah, so that's a big one. You know, people can be concerned that they don't have the flow that they used to. They can't write their names in the snow anymore. Sorry, Mom. Those are the two biggest ones.
So, Nick, as we look at that, we're looking at the prostate, I would say, and the discussion goes to the prostate. Tell us a little bit about the prostate gland, why it's there, and where the problems come. And you can jump in, too, if you need to.
Yeah. Prostate is a funny bit of anatomy, and probably one of the creator's poor bit of planning. So it's a gland that sole job is to support sperm on its journey to help with fertilization, and it makes secretions, and it sits right at the base of the bladder, where the bladder funnels down and takes off to the urethra. And unfortunately, for reasons which aren't clear, most men's prostates tend to get bigger over time, and sometimes that enlargement results in obstruction, which makes it more difficult to urinate or contributes to a host of symptoms that Dr. Sanford was talking about. It isn't always A equals B. In other words, just because you have a big prostate doesn't mean you have a hard time peeing, but the two do often go together. And so, as Dr. Sanford was saying, it's a big part of community urology. A lot of men come to see us for urinary issues, which probably are, in the end, related to their prostate in some way.
Dr. Inglesjerd, how do you evaluate the prostate?
That's a good question. So if a patient comes to my office, for example, and was complaining of a weak stream or feeling like they had to urinate more often than they used to, typically the workup begins with them answering a questionnaire that gives me a little bit of an idea of all of the symptoms that they're having. So it tells me how often they're urinating, if they feel like their stream is weak, how often they're getting up in the middle of the night, to name a few things. Sometimes we will have them urinate for us into a device that can calculate how well their stream is. And then oftentimes we will also calculate something called their post-void residual volume, which is how much urine is left behind in their bladder after they feel that they have emptied their bladder. And those are kind of the first things that we usually check out when they come in to see us.
Dr. Sanford, in your office, what do you do?
Oh,
for
the questions by far is 90% of the diagnosis. And then as part of the general exam, I always want to do a digital rectal exam, because there's not always a correlation between prostate cancer, PSA, and what you feel. So, but it's 95% of the diagnosis is just in talking to people.
The digital rectal exam, the finger wave, if you will, and then the PSA have been around for some time. I remember when the PSA emerged on the scene. We've been around a long time, Paul, and we've used it a lot. Where are we at the present time with digital rectal exams? And Nick, I'm throwing this one at you. Digital rectal exams and the PSA, are we using them as much as we used to? There was a period it seemed like we backed off, and now I think we're back again.
Yeah, that's a really good way to put it. It's a long history and there's a lot of details, but I would say this, as you're asking the question, the thing that came to my mind is that it does seem like things tend to wax and wane, and for better or for worse, we still don't have a better tool for finding prostate cancer early than PSA. And PSA is still a big part of the screening protocol. So if you really want to do up-to-date prostate cancer screening, PSA almost has to be a part of it. And of the two, between the prostate exam and the lab test is by far the more valuable of the two in terms of detecting prostate cancer. So you can still get a lot of information from the digital rectal exam, and if someone's new to my office, whether or not they come in for a PSA question or a urinary symptom question, I still almost always do the exam just to get a little bit more baseline information about what I think is going on. But specifically for cancer detection, the PSA, for better or worse, is still our best tool for detecting prostate cancer early.
Josh, it's been a while since I've been really, really active in practice. I'm still to some extent, but not every day like it used to be. What I remember is that prostate cancer, I kind of think of it as you can get it early on. They all look alike, and how do you determine what you can watch, what needs to be worked on? Like I keep thinking there's basically three different types. Do you want to help me separate that a little bit?
Yeah. So in the workup for an elevated PSA, typically the only way to truly diagnose prostate cancer is to do a prostate biopsy. Nowadays, oftentimes before we do a biopsy, we're getting an MRI of the prostate, which gives us a really detailed view of the prostate and can show us if there's any concerning lesions for prostate cancer. And that can actually help us do a more accurate prostate biopsy called an MRI fusion biopsy, which can essentially allow us to biopsy the lesion as well as do the systematic biopsies throughout the prostate. And if those biopsies do diagnose prostate cancer, it's basically based on what the pathologist sees under the microscope when they look at those biopsies. And they give it a score called a prostate grade group score that goes from 1 to 5, with 5 being kind of considered the most aggressive, most concerning type of cancer, and a 1 being very unaggressive, and oftentimes when it is a 1, we don't even consider doing a form of curative treatment, and we know it's safe to watch it. So that's probably what you're thinking of, is that score, the grade group score.
That's moved on since I last looked at that. That's great. Nick, I assume you do prostate surgery and cancer surgery and so on. So if you've got someone with prostate cancer, can you talk about that a little bit and how you would handle those? And Josh, you may want to jump in on this too. And Paul, you can probably like me sit back and listen for a minute.
Well, I think Josh had a great entry to the question, because the first part about figuring out prostate cancer surgery is who actually needs surgery. There are multiple forks in the decision-making road, and as Josh talked about, the first fork is figuring out if this is a person that needs to be treated up front, or is this someone that could be watched safely? And then if you do determine treatment, the next question is this a person that would benefit from localized treatment, in other words, surgery to remove the prostate or radiation directed at the prostate, or has the cancer advanced beyond the prostate, in which case you're thinking more of systemic treatment. In order to choose between surgery and radiation, there are multiple other forks, but the biggest one is honestly patient preference. If you look at the data from cancer outcomes, surgery and radiation are more or less equivalent, and they're both well tolerated. The surgery has to be on the right person. There's some criteria that we use to select who's a good candidate or who is safe for surgery, but ultimately you're looking for an outcome where by surgery you're going to get rid of the cancer. And we do that now robotically, and it's the wrong term to say it's standard of care, but functionally it is the standard of care, because virtually every high volume surgery center, urologic surgery center in the country does this robotically.
I assume you both do a robotic. Yeah.
Yep.
So what age should we start looking at people for prostate? That's one of the questions that's here. When do you start?
I have a couple of ways I look at it. I mean, the AUAs are kind of governing guidelines want us to start at 55, but I think that's, in most cases, that's probably a little bit too old, especially if there's any family history. And if you press most men, there's a family history. And so this is not guideline supported, but in my ideal world, I'd love to see a PSA by age 45. And if it's within normal limits, then maybe 2 or 3 years later, just to establish a baseline. And if I've got any concerns because of health history, then I'll start doing one every year at 50.
Paul, what are your thoughts?
Exactly the same. I get a baseline sometimes at age 40, depending. You know, people with family histories of malignancy, Lynch syndrome, any type of malignancy.
What's Lynch syndrome?
Lynch syndrome is an unusual genetic-based propensity to cancer, usually ovary, breast, pancreas. Prostate is not high up on the Lynch list, but you know, anything that I believe puts people at higher risk of malignancy, you know, first of all, just asking if their urinary symptoms have changed. When in doubt, check a urine for microscopic blood or microscopic hematuria. And you know, my job is to look at every patient as if they've probably got some horrible cancer in them and make sure I'm wrong. And that's just how I'm trained.
With the surgery, side effects of the surgery, in the past there was a lot of incontinence and sterility or inability to ejaculate and to have sex. With the robotic surgery, are outcomes better these days? One of the questions is does this affect the possibility of having children?
Go ahead.
Yeah. So in terms of ability to have children, it will essentially, when we do the surgery, we're doing a vasectomy, which is transecting the vas deferens, which is what carries sperm. So it would make it so that in the traditional sense, you wouldn't be able to have children. You would still produce sperm, but it would have to be retrieved in a different way if you wanted to have children after having a prostatectomy. The most common side effects after prostatectomy are urinary incontinence or leakage of urine, as well as erectile dysfunction. I have not done prostatectomies prior to robotics. All of my training was in robotics, but I would think that the symptoms are less severe doing it robotically compared to the open approach. The beauty of doing it robotically is we have basically a 3D enhanced view that is giving us the most detail possible to be able to see all of the anatomy when we do the surgery, which allows us to really preserve the muscles that are important to regain continence after surgery. It also allows us to perform surgery doing what's called a nerve sparing technique, the nerves that are important for erections wrap right around the prostate. And so we're able to basically sweep those nerves off of the prostate when we do the surgery, with the idea of leaving them behind so that they can recover and then allow men to have erections afterwards.
And it's surgery that's deep in the pelvis, which is very tight and complex, and
Yes.
I think you said that very well. The other one that comes up in the past, I don't know what's happening these days as far as radiation therapy, but it used to be radiation damage to the colon and those type of things. Are we still using radiation for this too?
Yeah, so in a certain population of patients, radiation is a better option if we feel that they would not be able to handle the anesthesia for surgery, or they have certain conditions that would not allow us to hold a blood thinner, for example. And in those patients, radiation still is a good option. We do have sort of a new technique that allows us to protect the colon, called space ore. I don't know if you guys are doing that, but essentially puts a little bit of space between the rectum and the prostate, so when they give radiation to the prostate, the rectum is spared from any radiation side effects.
Paul, I lost my question here. With the with prostate cancer, is this a familial disease? And if someone in the family has it, so my dad had it, and is this something I need to worry about?
Well, I try to encourage people never to worry, period. That's just praying for suffering. But like in my family history, positive for prostate cancer, I've had prostatectomy the old-fashioned way. So I think, I don't know the exact genetic loci. MGH6, is that generally the gene? But anyway, I always assume there'll be a propensity, if there's a family history, of ovarian, breast, or prostate cancer.
So to finish this one up, any one of you can answer this. What do you do to prevent prostate cancer, prevent BPH? Is there anything that a person can do, or you just live your life and enjoy it?
Enjoy.
Yeah.
I bet you every 90-year-old man
So
has little
smoking,
spots of
alcohol,
prostate.
and things like that, are those factors or not?
Still have never been
Never
proven
proven.
direct. I mean, I assume none of them help for
No.
most health issues.
Cheeseburgers help.
Yeah.
Yeah.
But for risk factors, there's only 3 known. One is being over 50, one is having a family history, and one is being African American. And so African American males should consider earlier PSA screening because of that. And family history means close relatives, so father, brothers, uncle.
Josh, because this falls into some of the things that you enjoy doing, or you're doing, tell me a little bit about bladder cancer.
Yeah, so bladder cancer, now that is something that is seen more often, and we know that smoking is basically the biggest risk factor to develop bladder cancer. You may have your primary care doctor check your urine in the office for signs of blood in the urine, or if you notice that you have blood that you can see when you urinate, that is one of the potential signs of bladder cancer, and would be a reason for you to get referred to a urologist for further evaluation.
Paul, what causes kidney stones?
Oh my goodness, you got the most common one.
We're
is-
going to kidney stones.
Yeah, oh, that's good. Gravel is needed to keep the roads non-slippery. But yeah, calcium oxalate, probably the most common. Uric acid, the second most common. And then struvite, these really cool little coffin-shaped stones, are the least common. But it's just where the concentrated urine has allowed things to go from being a solute into a crystal. So that's why you always want to be drinking gobs of water.
Other thoughts, gentlemen, as far as how to dietary carefulness or whatever, can you do anything to avoid kidney stones? So oxalates and fluids, and what else?
Well, kidney stones are complicated. There's multiple different
Many
kinds. Paul listed some of the most common kinds, but the reality is this. You and I might drink and eat the exact same things. I might get stones and you might not. And there's just some metabolic risk factors that some humans have. Some of it is probably, again, familial risk factors, but what we generally do to really answer that question correctly, if you have stones and you've been treated or you've had multiple stone events, we try to get a piece of the stone to have it analyzed. And then we often have our patients complete what's called a litholink, or a 24-hour urine test, which is actually looking at your specific metabolic risk factors for why you might be forming stones. So you can take the composition and you can take the results of that 24-hour test, and you can come up with a very specific reason, hopefully, why you're at risk for forming stones. And then our therapies are targeted as opposed to generic.
So if you have a, Josh, if you have a stone in the kidney, how do you handle that?
So,
And I'm suggesting a larger stone that's not going to drop.
okay. So if it's a stone that we feel like isn't going to drop, or if it were to drop, it would cause, significant discomfort and have difficulty passing. There's a couple ways that we could approach it, depending on the size. The most common way that stones are typically treated is with a procedure called ureteroscopy, where we use a small camera scope that we insert through the urethra and are able to traverse up into the kidney itself, which allows us to visualize the stone. And then we can use a laser fiber to basically break up the stone into small pieces, pull all those pieces out using a small basket to clear the stone out of the kidney.
And in the bladder, usually you can ride those out.
So if a stone gets into the bladder, oftentimes it won't cause problems anymore. That'll be the point where you'll be able to urinate the stone out and it'll pass on its own. Now there are situations where stones are too big and they won't pass on their own. And that's often seen in men that have BPH who aren't urinating well, not emptying their bladder well. And in those situations, we sometimes have to go in and use a laser to break up the stone in the bladder.
This is a question that came in. This person's doctor once told him that he wanted to use needles on the prostate to reduce the size of the prostate. Is this a common practice?
If I'm understanding the question, it was a fairly common practice, but hasn't been.
Oh, it was.
Yeah.
I'm old. I don't remember that.
Yeah. Yeah, but it's been not since I've practiced. Yeah, but I might because there might be referencing a newer intervention as well. So I'm not exactly clear.
They could be referencing a procedure called resume therapy, where you go in with a camera scope into the urethra where the prostate is, and needles are placed into the prostate, and then basically aqua therapy is used to cause the prostate tissue to necrose, and then that tissue then kind of sloughs away to open up the channel to allow them to urinate better. I bet that's what they're.
Yeah, there's the TUNA, the transurethral needle ablation, and I don't know if that's what they're talking about, but probably aqua ablation if this has come up recently.
Yeah.
I've never heard of it.
Well, thank God I haven't.
Paul, what do you tell your patients so you've got a gentleman that's older and is having incontinence and so on. What kind of things can you do to help him in the office? We've talked to surgical procedures, but there's a whole lot more that can be done.
Oh, yeah, no, behavioral things are so important. When people find themselves after watching 6 innings of a baseball game, find themselves all of a sudden getting up to urinate and they cannot make it to the bathroom, I try to remind them, first of all, have scheduled times. Every hour, just go to the bathroom. Even if you don't have a big raging emptying, it's still worthwhile just to move around. Good for your heart. Number 2, I know it's probably not as strict as before, but try to avoid caffeine and chocolate. The chemical group in the class methylxanthines in the old days were believed to cause increased prostate swelling, increased resistance, and then with that, increased retention of urine. You feel like you have to urinate out a quart, you urinate out a pint, you still got that pint in there. So I don't know what you guys think about methylxanthines in the diet, like caffeine and chocolate contributing. But usually I tell people to get off their duff and go out and walk around and urinate.
Any one of you want to discuss sexual health as relates to the advancing age and the problems that men have?
Sure. Any specific question or?
Well, my understanding is it's important to continue it, and that being sexually active is not a bad thing as far as taking care of the organs of men as they get older.
Yeah, I think I understand what you're asking. So one question I get asked, Josh, I don't know if you probably have the equivalent, but a patient will come in with sexual health questions or urinary issues or what have you, and then there's always the tagline, "Is that normal?" And I think that's a common perception among men who are getting older, is that there must be some natural decline, or this is just part of it and this is all normal. And I just usually start by,
I have to call it.
oh,
Sorry about that. Great job.
Darn, it's
Thank
just
you.
getting to the best part.
yeah.
I really want to thank our panelists, Dr. Josh Inglesjerd, Dr. Nick Johnson, and Dr. Paul Sanford, and our medical student volunteers, Michael Gutman, Alexis Codet, and Kylie Scholke. Next week, please join host Mary Morehouse for a special on mental health, on a show on grief and loss. Thank you for watching, and good night.